Bismillahirrahmanirrahim. Today's our question is which one of the following is the most effective antibiotic to use locally for a patient with a mucopurulent eye discharge and a red eye, which is illustrated here. We can see red eye. So which antibiotic, this is mucopurulent eye discharge, which antibiotic we will use? First, we have to understand that what is the diagnosis of this patient. So from this picture, we can see this is conjunctiva, which is reddened. So the options are gentamicin, streptomycin, penicillin, tobramycin, chloramphenicol. The most common cause of reddened inflamed eye is bacterial conjunctivitis associated with mucopurulent discharge. Suspected bacterial conjunctivitis is treated empirically with a broad spectrum topical ocular antibiotics. So usually chloramphenicol. Correct option is the E, which is chloramphenicol. Here we can see the close picture of this conjunctivitis. The patient should be advised about eye hygiene to avoid spreading the infection. Swab culture is usually reserved for persisting or recurrent infections and may require changing to specific antibiotics or to a broad spectrum preparation such as tobramycin. Neosporin, a combination of polymyxin, neomycin, and gentamicin, should be avoided because of the high risk of local allergic reaction. The other antibiotics, gentamicin, streptomycin, and penicillin, are not appropriate for initial treatment. Viral conjunctivitis causes a reddened inflamed eye with mild discomfort, a watery discharge with mild foreign body sensation, and photophobia. It's commonly caused by an adenovirus and regular epidemics occur. It is often accompanied by associated preauricular adenitis. Symptomatic treatment normally sufficient, and the infection usually subsides after about a week. A secondary bacterial infection often supervenes and should be treated with antibiotic. Adenovirus conjunctivitis is highly contagious and patient must be advised about the ocular hygiene. So this is the bacterial conjunctivitis in which some mucopurulent and reddened eye. So chloramphenicol is the treatment of the for this condition. 60-year-old woman has a history of several years of pain in her left shoulder when hanging out, washing, and raising the arm above the head away from the body. After a recent lifting strain, the pain became acutely much worse, and she says she is now unable to lift the arm up at all. The illustration shows here her trying actively to abduct the arm and represent the limit of her movement. On palpation, her deltoid muscle is actively contracting. The arm can be moved passively to full abduction. Which one of the following is the most likely diagnosis? Exacerbation of glenohumeral arthritis, adhesive capsulitis or frozen shoulder, rupture of supraspinatus tendon, dislocated acromioclavicular joint, osteoporotic fracture of surgical neck of humerus. An acutely torn rotator cuff mechanism, complete rupture of the supraspinatus component, results in an inability to abduct the arm more than about 40° in the presence of an actively contracting deltoid muscle, as illustrated here. Acute spontaneous rupture rarely occurs in a previously normal tendon and usually follows previous age-related or occupational degenerative changes, particularly affecting the supraspinatus component. The supraspinatus tendon has a major role in maintaining glenohumeral opposition during abduction, particularly in the coronal plane, and assisted by the action of the deltoid and other muscles. When the tendon suffers acute rupture, active abduction cannot be inhibited despite deltoid function, but if the movement is initially assisted, the deltoid can subsequently continue abduction of the arm above the head. A normal rotator cuff is unlikely to rupture, but previous symptoms previous symptoms of tendinitis may not necessarily precede the acute episode in response to an excessive lifting strain. Glenohumeral arthritis, adhesive capsulitis, fractured surgical neck of the humerus give a global painful restriction of the movement. Dislocated acromioclavicular joint give a characteristic steep deformity of the prominence of the shoulder. So the correct answer is a rupture supraspinatus tendon. A 5-year-old boy complains of acutely painful defecation with spotting of blood on the toilet paper. Which one of the following is the most likely diagnosis? Painful defecation with spotting of blood on the toilet paper, intussusception, anal fissure, Meckel's diverticulum, juvenile polyp, Hinosh scholin purpura. Whenever we see the painful defecation, the commonest diagnosis is the anal fissure. Anal fissure is the most common cause of rectal bleeding in childhood, usually due to passage of a hard, constipated stool causing bright blood on the surface of the stool or on the nappy or toilet paper. So correct answer is B, which is anal fissure. Each of other responses, intussusception, Meckel's diverticulitis, juvenile polyp, and Hinosh scholin purpura can cause rectal bleeding, but none approaches anal fissure is a frequency. While intussusception does occur acutely, it's usually associated with bouts of Kolke pain distressing the child who may look quite obtended after the bout. The stool has an appearance described as a red currant jelly. Meckel diverticulum may be associated with a central abdominal pain and may have a quite profuse blood loss, even severe enough to cause a significant drop in hemoglobin rather than spotting on the toilet paper. Juvenile polyp are unusual and generally are asymptomatic. If bleeding is associated with them, the blood is usually mixed with the stool rather than on the paper. Henosis colon purpura commonly present with abdominal pain, vasculitis, rash, and preauricular swelling and with painful joint. It may be associated with intussusception, with pain and a bloody stool, but not with spotting of blood. So anal fissure is the correct answer.